So, well, good evening, everyone. It's just us three, so it'll be a little bit more less formal with a smaller class, and that's okay. But my name is Dr. Pano. I'm a chiropractor with Chiropractic Company up in Mequon. So if you take 76th Street from here and go all the way north, about 15 minutes, my office is right on 76th Street. So it's pretty close to the high school here. Um, I've been teaching for the rec for the past 4 years. I've been in practice for 6. But my office specifically in Mequon sees a lot of vertigo. And so we do some different things for that in the office. But while I teach for the rec department, it's very clear to me that when people take these classes, they either want to get better, there's something going on, and they want to get better, or there's something they're trying to preserve, some kind of health they're trying to preserve. Is that kind of what we're experiencing? Yeah, for either health preservation or trying to change something.
I want to see if there's something new and different.
Something new and
Where I
different.
haven't experienced it. A lot of my experiences firsthand.
Okay,
The knowledge that I got about it,
sure.
of it firsthand.
I got you. Well, we'll dig into it, and like I said, it's less formal, so we can probably go back and forth a little bit. Normally, it's like questions at the end, but if we need to go back and forth during it, that's totally okay too. But when I work with people, and especially when I work with people at the rec department, as we try to change things or preserve things or get more information, insanity is doing the same thing over and over, expecting different results. So my goal for these classes is one, to provide a lot of informational value. Number one, because that's why you guys are here. But number two, also to provide an opportunity if there is something to do different, and that way we can potentially make change. Okay, so with that, our agenda is going to be kind of going over what is dizziness and vertigo, and what are different diagnoses of those, as well as what are the treatment solutions and what's best for me. At the end of the presentation, too, like I said, since you guys will be sitting here for the presentation, I'd like to offer a solution or a gift, which ultimately is to see if there's anything different we can do for you at the office. But I'll get to that at the end, okay? So, vertigo and dizziness. What is it, right? So, 1 in 5 adults experience some kind of dizziness or vertigo in the last month. And then when it comes to the American, National Institute of Health, reports about 7% of Americans will suffer some kind of dizziness at some point in their lifetime. But a big thing when it comes to vertigo and dizziness is kind of trying to sift through, is it dizziness or is it vertigo? Because it sounds like from your both experiences you maybe have had vertigo, and it's definitely not the same thing as dizziness. And to those who've never had it, it's hard to explain, but if you know, you know. It's not very fun. And so when you have dizziness or vertigo, it's going to significantly impact your acts of daily living. Driving restrictions. It's going to cause more psychological distress. I was working with a woman earlier this month who has been dealing with vertigo for the past, since gotten worse since March. But and constantly from March till when she started seeing me end of October, early November. But she was like, I have to go on Medicaid. She's like a high CFO executive, and she was like, I'm not going to be able to do my job if this continues. And so the stress of thinking about the dizziness and vertigo will impact us in so many different ways, which is a fear of future injury and other health issues. So it's a big deal. So trying to quantify what is dizziness. So it's a non-specific term that describes the sensation of altered orientation of space. So that's not the same as vertigo, but it just means something is going on in here and I can't get even. I don't know what's going on. That's really what the general term of dizziness is. It can be visual, it can be proprioceptive, it can be vestibular. Those signals make up our information, how our brain perceives the world. But when it comes to that, when one of those are altered, that's when we get the sensation of dizziness. Proprioceptive means, so proprioception is your body's ability to tell you where you are in space. Meaning, if I stick my hand out, my brain needs to be able to feel and understand that it's here and not here. And there's lots of nerves to understand how that happens. Mm-hmm. So that's what that means. Versus vestibular is overall balance, right? And that's both with eyes and in our ears. And then the visuals is just purely seeing. Our brain is looking around and actually creating a picture of what's around us. So that's how we understand space. When it comes to vertigo, it's the illusion of movement, usually that of rotation. The room is spinning around you. Not the same thing as the I can't stand straight. Something's not right about my orientation, but the room is spinning. That's a big differentiating term. Nerves from the internal ear maintain a balanced rate of firing into the balance center of the brain. Meaning, when it comes to vertigo, the ears are extremely important. You guys mentioned Epley's maneuver, and we'll talk about it more. I'm sure you've heard and read and talked about crystals in the ear. It's absolutely huge when it comes to vertigo. Um, but when there's asymmetrical, meaning one side is moving differently than the other, involvement of the activity within the inner ear or the vestibular system, how we're balancing, that's going to lead to the illusion of movement. Okay. So, how I simply explain that in my office is if what our eyes see don't match what our ears feel, the wires then get crossed, and then everything starts to spin. Does that make some sense? A little bit more normal language. So the difference is trying to identify is things moving around you versus is things just not right. Those are the two different things because that'll give us, doctors need to understand what the different diagnosis possibilities are. Okay. So that's more in the vestibular system. So I gave you guys a stress survey that's both kind of general, but as well as, there's some stuff about dizziness and headaches on there too. And so if you guys have done that, awesome, but we'll talk about that more at the end as well. So when it comes to somebody in the office for vertigo, we're going to first do a history, right? And when you're talking to somebody or you as an individual trying to figure out what's going on, you need to identify, is it true vertigo? Is there an issue with their nervous system, not just necessarily their ears, but is there something actually wrong with their nerves, their spinal canal? Is there a pattern? Sometimes vertigo will onset every time I bend over or every time I stand up, and then it happens. If it's just constantly, that's a little bit different. There's different feelings like syncope, like the feeling of fainting. Is there like auditory disturbances? Can people hear things? Tinnitus, right? Might be a word you've heard. Unusual eye movement. This is a big one. This is how, like you said, the physical therapist kind of looked at your eyes and said, yeah, there's definitely a lot going on there. We'll talk about why that is in a bit. Any past head or neck trauma. When your neck is injured and your neck becomes damaged, it's going to alter everything else of how your brain understands the world and proprioception. I actually had a gentleman. He just skipped the class and he just said, "I saw your thing in the Milwaukee Rec Department. I just thought I would come in." So he just comes in my office a couple of years ago, um, and his neck. He was 70 years old. He'd been dealing with vertigo for 30 years, and he took so much meclizine it was like candy. He had like a little pill bottle, like a necklace, and he would take 8 to 10 meclizines a day. And he just constantly lived in dizziness. And he's like, I don't know what you're gonna do, but like this is, let's see what you got. The end of the story is he barely takes meclizine, maybe once a week, and his vertigo is gone, and he just now kind of continues with chiropractic maintenance. But why I'm bringing this up at this point is because his neck had so much arthritic change, it was to prevent his head from moving, so he had less dizziness because he'd been having it for 3 decades long. And actually, before we could even do our maneuvers that we needed to do, we first had to work on his neck range of motion. And the second he started getting more neck range of motion, he was driving. He calls me from the side of the road. He says, Doc, I turned and checked my blind spot for the first time in years, and everything started to spin. I was like, that's good, but not good. Are you pulled over? The answer was yes. And so he would not be able to actually turn his head because his body had a defense mechanism, an arthritic change to prevent himself. Now, this is kind of the opposite of saying past or head neck trauma, but still identifies the importance of the neck when it comes to our vertigo. Past medical history and symptoms. Are you taking any over-the-counters, drugs, supplements, or any other kind of prescription or drug use or alcohol intake? These are all important things to know. When it comes to the physical exam, what are some other things? Is there any damage to part of the brain called the cerebellum? Um, is there any hearing loss? What's their muscle strength? That's a neurological test. Gait function. And then over here, nystagmus. Have you guys heard this term before? Have you heard of this term before?
If I did, I don't recognize.
Okay. We'll go over, I have a slide describing nystagmus, but this one is big for the physical exam. Essentially, are the eyes shaking? Okay, and which direction are they shaking? Because that'll give me a lot of information. If the pupils are abnormal, that gives me a lot of information on their nervous system. Other ocular movement. So when I'm testing people, is it their eyes are shaking, or can their eyes not actually follow my finger? Because it's a muscular issue. There's 6 muscles that control eye movement. And so I've had to send people to specific physical therapy for eye training. It wasn't dizziness, even that she was experienced dizziness and vertigo. It was her eyes not able to keep up, and she needed eye specific exercises, which is a little bit different, but is in this realm. So on and so forth. There's lots of physical examinations that we can look at. Now, this is that word, nystagmus. So this is the eye shaking back and forth. When I see this, that tells me that what the eyes are seeing, what the ears are feeling, don't match. Sometimes people shake a lot like this. Sometimes it's a little bit. Sometimes it's relentless and it just goes back and forth. But it can go side to side and it can go rotational. I've not seen it, but if I ever see it up and down, that's a ER visit immediately because they're having a brain hemorrhage. And so looking at somebody's eyes tells me a whole lot of information on what's happening to their vestibular system and their nervous system, and if they're actually a candidate for the type of care that we do at the office. That normally they don't sense it. Sometimes they can. Yeah. But you've been told that your eyes shaked like that? Yeah.
And like you say, I had to get
Mm-hmm.
the eye brain training
Yep.
thing with the letter A.
Yeah. Oh, yep.
So yeah.
Yeah.
But again, I didn't know that I couldn't sense it.
Yeah. Most people don't
And
sense it.
It didn't prohibit anything I needed to do. It was just that.
Yeah.
My brain wasn't in sync with.
Yeah, in a way, yeah, it could have been. Yeah, in your case, could have been.
When I went into the ER,
Mm-hmm.
it was a teaching hospital.
Oh.
And so they had.
Was Freighter?
They were was Freighter.
Yeah.
The first time, and so the doctor said to the student, "Look at her eyes
Mm-hmm.
and see them." And I didn't feel it at all.
No,
yeah. 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 Most people don't.
I felt good that they could see something.
It's reassuring something was going on.
Yes, right. Exactly.
Yeah. Exactly.
Because I guess it's pretty common.
It's more common than you think, but it's.
The more I talk about it, the more people.
But and the thing with it is a lot of people just suffer through it and they don't, because like it gets bad enough. You go to the ER. Most people don't get hospitalized, but sometimes they'll give you an IV, they'll give you meclizine, and then they just say, de-stress. That's like could be heart issues. It could be a whole lot of things. Yeah, exactly. So they got to tease that out when you go to the ER that way. But when it comes to this, and when it's not something that's emergent like that, they don't know what to do. And that's just kind of how it is. So it's important physical exam to understand. Yes, exactly. Yeah, my blood pressure is okay. Yeah. Right. So there's some other types of testing that can be done. So when you are feeling dizzy, they might do a CT of your brain, making sure you're not hemorrhaging, you don't have any masses. They might look at your glucose levels and just do any kind of neurological testing, because sometimes people get dizzy when they have low blood sugar. they could squirt cold water in your ears and see if they see any eye movement there, and that could be an issue with a different type of your ears. You can do MRIs, you can do angiography, they can do a whole lot of testing. But when it comes to, if you take a good history and understand what's going on, either A, people are helped in my office, or B, we're able to co-treat and people can have a better quality of life.
That last one, was that like ear testing? Because both times when I had
Yeah.
a surgeon, they wanted to test my
Test hearing loss. Yeah, and that's good. That's good. Like, do you have any hearing loss? When do you have hearing aids? And that's a question that we got to go through without a doubt.
So I taught medical terminology.
Yeah.
And I wish I would have had that word.
Yeah. People are like, electronystagmography. Yeah. For sure. For sure. For sure it would have been. Yeah. And then use it in a sentence properly, right? Yeah, for extra 2 bonus points. So when it comes to diagnosing vertigo, there's lots of different types. So there's a bigger category called labyrinth disorders, and that's the most common cause of true vertigo. The word labyrinth in reality is referring to the inner ear, this part right here. What's called the otoconia is in here, but this is literally called the semicircular canals and called the labyrinth of the ear. And it's just these crystals that move around. And so it's all categorized by labyrinthitis, as a kind of a general term. But so there's labyrinth disorders, and there's 5 types. There's benign proximal positional vertigo, which is the most common that I see. And that's the kind of vertigo that's most easiest to treat in my office. We get great success with. Labyrinthitis is more of inflammation. For whatever reason, there's inflammation inside that ear. There's Meniere's disease, which is autoimmune, and that can impact the inner ear, but it's also autoimmune. So what you're eating, your stress levels, antibodies, those are all impacted by it. And I've had some people come in and we've decided it's most likely Meniere's disease. Vestibular neuritis could be an issue. Same with acoustic neuroma. So this is like a mass inside the ear. These are the 5 most common types, but these 2 are the easiest for me to tease out. So when it comes to benign proximal positional vertigo, let's break that down in medical terminology, right? Benign, meaning it's not life-threatening, right? Proximal, meaning in relation to one another. Positional, meaning how I move will impact it. And vertigo, meaning the sensation of the world spinning around you. And it's extremely common, like you're talking with your friends. Most people kind of have it and they don't realize they do, and they just kind of, it either goes away or they just kind of suffer in silence about it, right? So otoconio displacement means the crystal. Otoconia is the crystal in the ear. So it means that the crystals within that labyrinth aren't in the right position and they're stuck. Okay. When it comes to BPPV, there's no hearing loss or tinnitus typically associated with it. It's usually short episodes brought on by rapid head position changes. Okay. Usually a single position that gives you the most sensation of vertigo, but it could be multiple. But we'll see horizontal or rotational nystagmus, that shaking of the eye, and kind of more in crescent pattern after a slight delayed period. Typically can be reproduced at bedside with positional maneuvers, which is like the Epley's maneuver, there's Saccad's maneuver, there's a couple maneuvers, which we're, I think, in the next few slides here. But another one to talk about is labyrinthitis. There is hearing loss and tinnitus with this. Okay, so if you talk to anyone like, oh yeah, I get ringing in the ear and I'm dizzy, or I ring in the ear and the world kind of spins around, that's something different than what we just talked about. Okay, it's usually random onsets, and then there's different types of labyrinthitis, whether it be it just happens chronically for years without some kind of reason. Toxic, meaning there's infection or there's not the right chemistry in their body, whether it be medications, supplements, not, their blood sugar, whatever reason, there's something going on inside their body. There's acute, and then there's kind of more, like I said, infection based. Meniere's disease. So this is the triad of vertigo, tinnitus, and hearing loss. When you have all three, when it's harder to hear, you have ringing in the ear, and you have vertigo, it's a higher chance that it's Meniere's disease. Okay, so often patients have eaten salty meals prior to their attacks. So this is the nutritional one. So sometimes when it comes to, without getting too nerdy about just all of this, how our nerves work is very salt dependent. And so if this person has a lot of salt, then their nerves start firing a lot faster, and then they get this kind of onset. So having a different type of diet is extremely important for someone with Meniere's disease. So what are some other things I can talk about? Usually lasts for several hours. So they're getting all of this for a couple hours at a time compared to the short onset of benign proximal positional vertigo. Tinnitus, do you guys understand what tinnitus is? Yeah, you understood tinnitus before? So it's kind of lower pitched. Yes, exactly. And then there's typically no central nervous system symptoms or potential vertigo are present by themselves. Um, so we're going to skip vestibular. And then so that was peripheral vertigos, but this is more central, which means to the body, more center. So a lot of this is more arterial or artery. So there's a vertebral basilar insufficiency. So for whatever reason, the blood isn't being supplied to this area. That can sometimes cause vertigo. Wellenberg syndrome is a genetic syndrome which involves the blood, and that will cause vertigo. And then when you have hemorrhaging, that can cause like everything is spinning. So hemorrhaging of the brain. Okay. So when it comes to differentiating what's going on, I'm trying to think: is there head trauma? Because I see many athletes, and athletes will, when they have concussions, might have vertigo. And I might see nystagmus there, but they truly don't have vertigo. It's their eyes and their nervous system being shaken because of the head trauma and the concussion. Okay. Whiplash injuries can cause issues with this because, like how I was describing, when there's issues with the neck, because of how close the neck is to the ear, this will impact it. Okay, so when you have whiplash injuries, subluxation, or even TMJ issues, this can lead to symptoms of vertigo. Stress is huge, absolutely huge. I have had somebody who's had benign proximal positional vertigo, and stress is just the fire on top of it all. They have all the other qualifying symptoms, all the qualifying etiology, but what's really pushing them over the edge is what's going on in their life. This one person I'm thinking about was used to be treated at her office, many years, moved to California, came back to close like on a multi-property deal or something like that, and was very stressed out about it. She had vertigo. We cleared the vertigo in 2 visits, but she was still feeling like everything was spinning around her, that the room was spinning. But when we check her eyes, she's all clear. Well, second she closed on the deal and signed the paper, vertigo was gone. So there was a physicalness to what was going on, but the stress amplifies the feeling, and that will make it feel like it's worse or still there, but you've actually cleared it. But the stress makes you feel it more. It will take a small case of vertigo and make it feel big. Okay. And then adrenal fatigue. So our adrenal glands sit on top of our kidneys, and if you are stressed or chronically stressed, or you need a lot of caffeine and your adrenal glands aren't working properly, that will ultimately cause vertigo symptoms as well. And when I look at the pupil, if I see the pupil can't constrict under light and stay like this, and it kind of bounces back and forth, that's a sign of adrenal gland issues. And that's just more nutritional, that's stress management. And, that ends up being part of people's plans on getting them out of their hole. So when it comes to the solution and treatment plans, right? So back to, this is going backwards. Oh no, I see what's going on. So when it comes to what do you do, right? Well, for benign proximal positional vertigo, the most common cause of vertigo, that's me breaking down the word. That's what we primarily will treat at the office. So the theory, what I've already kind of described, is the otoconia become displaced and they're not moving the way they should. Yeah.
Can you give me what I visualize is
Hmm.
like little pieces of sand?
Sure.
Like sand grains?
Yep.
Is that what they're like?
Yep.
The crystals? Okay.
So how I describe it, so we have three tubes in our ear for X, Y, and Z, right? Like in a math grid. Z for the width or depth dimension, and it goes X, Y, and Z. And it's supposed to be a circle, right? So just like a toddler's toy or a dog toy that has crystals, like or kind of like beads, they're supposed to swirl in there. And you can imagine now three circles or three tubes here, here, and then coming at you. Okay. So those are supposed to move and move with each time we move our head, and X and Y and like Z.
The crystals are supposed to move?
They're supposed to move.
Okay.
Yes.
They're there all the time.
Yes. And
it doesn't disappear because you have vertigo.
correct.
They're always
They're always, and there's always
I didn't
supposed to
know
be.
they were always moving.
Mm-hmm. Yep. Because that's how your brain senses it. It's literally like a child's toy. As the beads move, your brain picks it up. Oh, you're rotating. Your head's rotating. Your head's going up. They're always supposed to be moving, but the issue is when they get stuck. So if they get all clumped right here, or they get all clumped in one position, what's happening is that not all of them are moving, or none of them are moving, and the body senses that they're not moving, but you see that you're moving. And now your body doesn't know what to do. What the hell's going on? I'm getting told you're not moving. I'm seeing you're moving. Is the world coming crashing down? Feels like it, right? Um, and so, in essence, these crystals are supposed to move. And when they get stuck, they look like that. When they get stuck, that's where the issue is. Okay.
Like, how many are there?
That's a great question, and I don't know the answer to that. Yeah, it's a lot. At the top of my head, if I were to pull out a number, I would imagine thousands. I'm not sure a million, but I'm sure there's hundreds of thousands of them, and they're all super small, very, very, very small, and they're all supposed to be moving. And yeah, it's
they've always been there all your life.
Yes.
And they will always be there.
Correct,
Okay.
correct, exactly. So, but I've not been asked how many are there. Yeah, yeah.
Do they all need to get stuck, or like
They can be partial. It doesn't.
partial
Yeah,
okay.
yeah. Like think about it like a blocked artery, right? You know, if part of the artery is blocked, it's going to create bad blood flow to your heart or something like that. In a similar way, if some of them are stuck, now they're not all moving. Now you're not communicating the same way. Yeah, good question. So management of this, a lot of chiropractors will say they treat vertigo, but what they're really referring to is if your neck is subluxated or not moving, adjustments can help, which is true because there's an impact on the neck. But we do an advanced Apley's maneuver, not just a 30-second thing that maybe you've done, but we do an advanced one. I'll describe that more in a second. But outside of Apley's maneuver and chiropractic care, you can do adaptation exercises, which sounds like you've done, kind of training with your eye, and I will give eye exercises to people. But nutrition can impact it, not so much like Meniere's disease necessarily with salt, but it can impact it. Stress reduction is huge. You could have surgery. Somebody could go in there and try cutting it up and removing part of the tube, but I wouldn't recommend it. But there is some people have such bad symptoms and haven't found relief, but that's just what they do. Meclizine, we've already been talking about that, and obviously we can do nothing, and that's not advised, right? So Apley's maneuver, when I do it in my office, it takes anywhere from 8 to 25, 30 minutes. So you'll see essentially motions like this, and maybe you've experienced this in a teaching hospital or by a physical therapist. But what I'm doing is if the theory is that these crystals get stuck. I'm utilizing gravity. Gravity's always pulling down. So just like Planko, when you drop a bead and it goes from side to side between all the pegboards, or like that's not like I'm going to use like Planko, I'm going to try to use gravity to try to loosen these up. So what we do is we don't slam your head. Well, this looks very aggressive. I hope no one has ever gone like this. But there are people that say that's what you're supposed to do, like Dick's Hall Pike maneuver. But as we bring your head down, gravity is pulling down. You have one ear on one side versus the other. Gravity will try to move those crystals in that one specific tube. We go to but what I'm doing here is I'm looking at your eyes to tell me. We said your eyes will get the nystagmus when the crystals aren't moving the way they should. So when your eyes calm down, that's when I move to the next position. So we go from one position to the next position, and your eyes will shake, and then I wait for the eyes to calm down. We go to the next position, I look at your eyes will shake, and they'll calm down, and then eventually we sit you on up. There's about 5 or 6 positions, 7 positions, really what Epley's maneuver. But if you just do this really fast, you're just hoping that there's a few of those crystals stuck and you're just going to knock them loose right away. I find that doesn't really work based on other people doing that. And when we do it like this in the office, we get a really good results. Does that make sense to you too? Yeah.
Well, I've had it done to me.
Mm-hmm.
I've done it at home, and it's always worked.
Yeah. Good.
Luckily and gratefully.
Good.
The only one thing though that I struggle with is when I had a physical therapist do it, I had it in both ears.
Yep.
So I can never tell at home on my own
Mm-hmm.
which
So,
ear it is.
Yep.
And if you do it one way
Mm-hmm.
with one ear, then you're not supposed to then turn around
And do it the other
way.
Right. Yeah.
So any thoughts on that?
So I see it a lot of time in both ears, and how I can tell that is depending on how their eyes are moving and what side seems worse, or if they both seem worse, or depending on what position their head is in. It can be in both ears, 100%. But you're correct that you don't want to do both sides at the same time. And so if you do one side, just let it sit, and then if you're still feeling it the next day, you might do it the next day on the opposite side if you're doing it by yourself.
Well, that's contrary to what the physical therapist told me.
What did you hear?
Oh, and maybe it's just specific to my case.
Sure. Yeah.
But it said definitely do it on both sides.
Okay.
Do it on the side first that you feel is the worst.
Yeah.
So go on that side and then lay there until you think it kind of clears up.
Yeah.
Then go to the middle again and go to the other side.
Sure. So I was
told to do both.
Well, you do both in the maneuver, but the maneuver is on one side, but you still do.
Yeah. Both ears end up being affected is correct with the maneuver. And what you're saying, because you go and turn one way, then you turn the other way, and gravity's always pulling, whether if my head is laying like this, gravity's pulling down both on my right ear and my left ear. Regardless, you're correct in that. But if you do it on both sides, there's a chance that you can kind of undo what you did. So not trying to say your physical therapist is wrong, but I tell people if you're going to do it at home, number one, I try to make sure they do it very specifically. But two, I would tell them to only do one side, and I don't repeat this thing twice. Yeah. So that's.
You start like if I think it's on the right side.
You start on the right.
Start on the right.
Yep.
But within the maneuver.
Yes.
I'm going back.
Yes. Yeah. Or you're correct. You're affecting both sides, but ideally you're stay on one side and then you're rotating to the other side, and then you're kind of getting up. So it's kind of like that. But I hopefully and that's why it's because there's many diagrams of this. And I have plenty of people try Epley's maneuver at home, and it makes them worse. I'm glad it's worked well for you guys. I'm not telling you not to do it.
found a YouTube video.
Yeah.
Well, that's what I said. It's on YouTube
Yeah.
as well.
Yeah.
Yeah, it's not so much that well, nevertheless.
It's
I don't immediately go to the next side. Just
Yeah.
take that pause.
Yeah.
Then you go to the other side.
Yeah. Yeah.
For a bit.
Mm-hmm.
Then, like you say, then you get up.
Yeah. So
that's the most important part. You need to get up and sit on the side of the bench or bed or wherever.
But then you don't do it again. You don't go
If you're
down
still
again.
busy, as a matter of fact, the physical therapy that I had was if you're still feeling dizzy, do it again.
And so the difference of when I'm doing people, since I'm doing 15, 20 minutes, it's a long time for their nervous system to recalibrate.
Yeah.
So that's also why I'm only telling people to do it one time. Because if you're doing it, my opinion, a more thorough way, it's a lot. People feel fatigued. They feel drained. They're like, oh my gosh, I just need to sleep. Because their nervous system is resetting and they're recalibrating. So each person, it depends. It depends on what you're doing. So when it's benign proximal positional vertigo, all I'm saying is in healthcare, everyone's individual, and so some things work for some and versus others. This is just how I found the most success for the most general people when people come to my office. Mm-hmm. Yep, but the rule of healthcare is if it works for you, great. that's correct. But my goal for most people is to get it so that it doesn't keep coming back. But the likelihood, if you have BPPV, is once you're in the club, you're kind of in the club and you can't get out. But I have people go months and years without episodes in between, and that's really what we're shooting for once we clear it up. Like I told you about the gentleman who had it for 3 decades. So other maneuvers you might have heard is Samant, Dick Holpike, and the Foster maneuver. The reason why I use Epley's maneuver, and maybe why you were told to use Epley's maneuver, it's the most studied, has the most success, and therefore is the best in my opinion. But other people and other PTs might try these other ones in other places. Not to say that they're wrong. I just think Epley's maneuver is the best. Okay. So
for all types.
For all types, yeah, yep. So why would a chiro be helpful for benign proximal positional vertigo? So like we've kind of alluded, when your upper cervical spine is misaligned, your inner ear, this is somebody's hearing, it's right here. So the proximity and the tension between the vertebra, the muscles, the fascia between here and here is so close that it's going to be impacted. Number 2 is when you have upper cervical issues, it's going to be impacting your brainstem, which will then impact everything else. When it comes to the jaw, so here's the jaw and the TMJ joint, again, super close. Sinus issues are a big, it's something I look for. You have sinuses here and here, and when you have plugged up sinuses, allergies during fall season change or beginning October when the leaves started to change and fall, and there was mold and disease on fallen leaves, I had so much vertigo in my office, it was insane. And my vertigo type in like my calendar is blue, and so my calendar just looks blue. I'm like, okay, I know it's allergy season because people are coming back in with a vertigo. So sinus issues are a big deal, and then the inner ear, which we've spent so much time talking about. So when you have upper neck issues, sinus issues, TMJ issues, and I can see that nystagmus telling me inner ear issues, then those are 4 really good signs that on top of your presentation and other qualifying things, that benign proximal positional vertigo is there, as well as chiropractic care and the care that I do in my office can help. And remember, on top of these 4 things, you add stress. Now it's just fire, gasoline to the fire. Okay. So when it comes to chiropractic care, overall addresses the health of the nervous system. Sounds like we're familiar with chiropractic care. I'm not sure if you've ever seen a chiropractor before. But when it comes to, I want to know history of injury, whiplashes. Like I told you, that one gentleman had so much arthritis and degeneration in his neck, that was a complicating factor in his vertigo case. When it comes, again, complicating of his vertigo case. And we're familiar with chiropractic, but when there's spinal subluxations or misalignments, when the joint isn't in the right position that it should be, the nerve will be impacted. The joints aren't moving the way they should, and then muscles get tight. So when we have loss of function in the vertebra and the nerves, it's going to be impacting it. So this is primarily how most chiros treat vertigo. It's important. I will adjust people when it comes to vertigo as well, but it's not the only thing that I'm looking at. Okay, but 100% it's impacted. So I gave you one sheets that kind of look like this that describe the spinal levels and where the nerves come out. So C1, C2, C3 are probably the most important issues, as well as when it comes to T9. But C1, I kind of on the screen highlighted dizziness, sinus problems, and vertigo. All the way down to T9, if that is subluxated or misaligned, you will have overwhelming stress because of the impact on the adrenal glands. If somebody continues to have chronic vertigo issues, you tell me would be important for those spots to be adjusted and make sure that they're moving correctly. It would seem so, right? Yeah, and I would agree, without a doubt. So when it comes to chiropractic care, it's extremely important, especially when it comes to the maintenance and prevention of it. But there's other things like nutrition, making sure sometimes I recommend vitamin B6, ginkgo, fish oils, like having enough EPA, DHA, chromium sometimes can help, specifically related to blood sugar issues, and then adrenal support. These supplements, or making sure you're having in the right diet, if you're getting good levels of this, that also will help prevent the onset of vertigo because of what it does to the nervous system. It's an herb. That's a good question. Where does it come from? A lot of where does it come from? You can get it in teas. Yeah. You're right. Yeah, it's mostly you get it in mostly a supplement form. It's not like a phytonutrient where you can have enough veggies and get it. It's more like it's more an herb. So if you go to an herb store, you might see it there. But which is why people take it in supplement form instead of just taking herbal teas. But if you want to go to an herbal tea store, you can get it from there too. So, good question. Yeah. Yeah, not just in general when it comes to supplements. If you're getting supplements from Walgreens, Walmart, Costco, that's not the good stuff. That's not right. 100%. Yes. 100%. But there's a reason. There's a reason why, right? Yeah. Other things you can do is stress reduction. So, as simple as it sounds, it's important, not just in your vertigo, but everyday life. But if somebody has like a high CFO person I mentioned earlier, stress reduction is very much needed in that person's life. But if I told that person, hey, that's all we're going to do, they would look at me like, all right, I'm going to the next person because they want results now, right? And this is important and impactful, but it's not the first go-to, but it can't be ignored. Making sure you have proper stress reduction in there, okay? And then surgical options, we're just going to skip over because we want to avoid that. These? Oh, yeah. The stress reduction?
Well, and just can you talk about the posture when you're sleeping?
Oh, sure.
Picture that is there.
Yeah. So in general, when I coach people with sleep, the best way to sleep is with a neutral spine. So what that means is we want your spine to be in a line. Okay. Sometimes people have way too high of pillows, not enough. And for them it's too soft. Sometimes too firm, creaks you up. Including that alignment is even like a pillow in between the knees. So In general, I tell people best way to sleep is on your back, second best is on your side, and third and worst is on your stomach. To that, it depends on the person, depending on what their x-rays look like, whatever else, or the symptoms, where the tightness is. But side sleeping in general is second best, and not something frowned upon, but definitely avoiding sleeping on your stomach. Did you have specific questions about posture while sleeping?
I've tried to sleep on my back
Mm-hmm.
because I've heard that's the best
Mm-hmm.
way, and I don't sleep well that way.
Okay. Just uncomfortable? Okay.
And I don't know how you know what pillow to use. Like,
Yeah.
I don't know. How do you know
Sure.
how, what
Mm-hmm.
kind of pillow? I've gotten the ones that are on the outside, and then they just like that.
Kind of like that. Mm-hmm.
But I don't know if it's the right
Size.
size for me.
Sure. I've had one person bring in a bag of pillows, and that was and that was very
Great
fun.
idea.
Not saying that that's necessarily what I would recommend, but it was fun to do. Just like I've had someone bring in a tuba for proper posture around how they're supposed to do their tuba. Anyways, but if you pillows like this are great, um, but you're right. Depending on your neck, it might be too high or too low. Biggest thing is, do you feel like you're jetting one way or the other? And when it comes to purchasing a pillow, what I tell people is, I want you to, I don't care where it is, if you're at Beth Bad and Beyond, or Beth Bed and Beyond, even that it's gone forever, whether you're at Target, wherever you are, take the pillow, put it on the floor, and lay on it, and try to see what that feels like. Because if you wait till you get home, it's not gonna work well. And I actually tell people they should go to mattress stores, because they will have pillows, and you can experiment and try many different types. And so what you're looking for is, one, if you have a partner that can tell you if you look kinked or not, but two, generally try to say, okay, well, I feel like I'm not leaning down. Like, when you really take notice on what's going on, am I super high, am I just a little bit, am I kind of in the center? So that's, you really just gotta need to experiment with the position. That's the biggest thing. I wish I could tell people there's one great pillow, that's all everyone needs, but I can't. Unfortunately, I can't do that. That doesn't exist. So.
I did buy a foam pillow. It was expensive.
Mm-hmm.
I think it's okay.
Okay. So, and then a good litmus test of that, is, are you continuing to get neck tension and shoulder tension and things like that? And if you are, there's other questions. Are you currently doing rehab exercises at home, or are you seeing chiropractor? Like, those questions are important, because it's not always the pillow, just because you wake up with neck tension, but it could be maybe the pillow's not correct. But if you're doing all those other things, then we can tease out, well, probably need a new pillow. So, a good question though. So, what's best for you? Conservative treatments demonstrate the best results. Finding provider, whether it be physical therapist, myself in my office, that can actually diagnose and provide you comprehensive treatment for you, is super important, right? Both when you have a flare up, as well as making sure that it doesn't keep happening. And preventative measures to avoiding future episodes is extremely important, right? So, when it comes to, um, number one, we need to have a correct diagnosis. Is it actually benign proximal positional vertigo, or is it something else? Because I've had people come in and say, this isn't what you need. You need to figure something else out. Yeah.
Well, I was going to ask you. Sometimes I'm washing dishes,
Mm-hmm.
and all of a sudden just get the lightheadedness.
Yeah.
And it's not vertigo at all.
Just lightheadedness.
Just lightheadedness. And
Okay.
I don't know. I watch grandchildren and like
Mm-hmm.
an infant.
Yeah.
And it's like, it hasn't happened, thank God,
Mm-hmm.
when I'm with them, but I'd like to figure out what it is.
Yeah.
And it doesn't happen maybe once a week.
Once a week? Maybe once a week?
And yeah,
okay.
And it's quick.
Yeah.
It comes and goes away.
Mm-hmm.
And it's like there is a fluorescent light in front of me. It's usually when I'm washing dishes.
Okay.
Like, oh, maybe it's that.
Sure. And when you're washing dishes, you're looking down, right?
Right.
So and you're saying the room's not spinning you, but lightheadedness, that's more of a dizziness, right? So it would still be, we double check your eyes, and things like that. Or is it, a possible neck tension thing? Is it a blood sugar issue? There could be a couple of things going on with something like that. Otherwise, just rushing to do Epley's maneuver every time you do that wouldn't be necessarily the best thing to do, right? But whether it's something else, benign proximal positional vertigo, Meniere's disease, if it's a centralized vertigo, probably need to go to the ER, which it sounds like none of us do here. Or maybe it's nervous system dysfunction, whether past head injury or neck injury, stress, or adrenal glands. Those can all lead to whether it be dizziness, vertigo, lightheadedness, right? So sifting out what's going on is a really important part, okay? So when it comes to a gift or opportunity, I told you guys in the beginning that for people that sit in my class, that I'll offer something in my office, and that tends to be a complimentary consult in my office. Where obviously we've already talked, we got to know each other a little bit here. It's an intimate class where it's just the three of us, but we really can sift through history and things like that. And that way we can figure out if this is right for you, or if we need to send you somewhere else, or co-treat somewhere else, or things like that. But like I said earlier, doing the same thing over again is insanity, expecting different results. So this gets you an opportunity to change and try something different. And so with that, if there's any other questions, I'd love to stay later and ask for them. But when it comes to this, this is something that's pretty much just an exclusive offer for the class, right? And so if you'd like to see, I know you're already seeing Dr. Van Scoik. But yeah, and Alan's awesome. Yeah, I just saw him on Friday, and so he's excellent. But even when it comes to the vertigo, if there's a little bit more that you want to assess, we can co-treat with Alan and things like that. So, but nonetheless, good, good, good. So with that, I'll stay and hang out. If you have any more questions or things that I haven't answered, I'd love to, answer those for you. But I appreciate you guys' time.